So as the physician is making decisions with the patient on the best treatment approach, there are several things that impact those decisions. Most importantly is the severity of the disease and guiding what types of therapies in terms of potency and method of delivery and what we know about them from a science perspective. But subpopulations of Group 1 PAH do impact that decision as well. So for example, we know that PAH in association with connective tissue disease is extremely challenging because the reason the patient has the PAH is the systemic connective tissue disease, which of course isn't going away. That remains there forever. So there's probably some ongoing risk to the pulmonary circulation forever because it is in association with the underlying connective tissue disease. And in general, we want to be as aggressive as possible with those patients because of that risk. And we know that if we are not as aggressive as we should be, that the patients struggle more than perhaps some of the other subgroups. It's also very interesting that in some of the information that has shown using, for example, 2 oral medications in different pathways as soon after the diagnosis as possible, what's called upfront combination oral therapy, which was shown in the Ambition trial to be beneficial to Group 1 PAH patients, also holds true in connective tissue disease. So based on that scientific information and personal experience, I advocate for patients with connective tissue disease with mild or moderate intermediate disease to start 2 oral drugs as early as possible after diagnosis. Obviously, if they're sicker, they may have to be on an infusion therapy or triple therapy. Patients with liver disease, portal pulmonary hypertension, the goal is not only to treat the pulmonary hypertension, but often it is to allow the patient to safely have a liver transplant, because ultimately the problem is end-stage liver disease or hepatic cirrhosis. And if that's not remedied, even if you control and improve the pulmonary hypertension, they're still at risk from the cirrhosis of having complications or even dying from liver failure. So the goal is to get the pressures down to a certain level, typically a mean pulmonary artery pressure of 35 or less, with a low pulmonary vascular resistance, and good right heart function, normal right ventricular function by echocardiography, to then allow the patients to safely have a liver transplant. So we work carefully with our GI hepatologists and our liver transplant surgeons. We discuss these patients carefully at multidisciplinary conferences as to the best therapy and the goals of therapy to get them in appropriate condition so that they can undergo a liver transplant if they're otherwise eligible, which has a very good chance of improving the pulmonary hypertension as well. Not 100% guaranteed that it would go away completely, but often a very favorable response, at least allowing less medication after the transplant. And certainly they feel better if the liver is now working properly. For Group 4 chronic thromboembolic disease, decisions around drug therapy really hinge on, is the patient eligible for surgery, what's called a pulmonary thromboendarterectomy, which, if successful, has a very high cure rate. About 10% of the patients may have some persistent pulmonary hypertension after the surgery, so they may require ongoing medication. But almost always, the initial therapy in that group, if they're not going to have surgery, is riociguat. A new intervention that's receiving more and more study is called balloon pulmonary angioplasty. And there's some information now that that can have a very positive effect on the pulmonary pressures and the pulmonary vascular resistance, really with similar or maybe even slightly better benefit than riociguat based on one study. But remember, it's an intervention. So it's going to have complications. So complications can be severe when you're working with a catheter in the pulmonary circulation. And so the potential complications may balance out any potential improvement over drug therapy. So that becomes an individualized decision between the physician and the patient. But we're very excited about the possible role of balloon pulmonary angioplasty in these patients that would not otherwise be eligible for the more curative surgery, the pulmonary thromboendarterectomy.